You like wine?
Oh.
Everybody does, isn't it?
Just tell them who you are.
Jo Franke in Netherlands, Nijmegen. Very difficult to pronounce. You don't have to do it. But you do like wine, isn't it?
Yes.
You do make a selection, isn't it?
Yes.
You know, that's top, isn't it? So it goes by the grapes, it goes by the composition of the soil, where you get good wine and you get bad wine. The same is with Glasionomos. You get good Glasionomos, you get bad Glasionomos. But if you want to have a good wine, you do have to follow the way that is needed to get to that good wine. If you deviate from it, your potentially good wine ends up in another category. If you use the Glasionomer, and I've not completely followed, the guy was very enthusiastic at a certain moment, and if you just say slick with Glasionomer, you're bound to have an inferior, a bad tasting wine. Have I made my point, or do I have to go on? No, thank you. Second thing, Glasionomos is a material that has a primary bonding between ions. It's different from the composite resin, where you first have to demineralize your dentin and enamel. That will create retention niches, and then you get your primer and bonding and your composite on it. The Glasionomer has a bonding. That means that calcium phosphates from both sides will leave, perhaps at the same time. One leaf from the Glasionomer platform and the other one from the dentin or an enamel platform. And then they meet halfway in a hyper-mineralized area. Because that's where the concentration of all these is very high. If you put that under acidic test, that part where these ions meet, that is the most acid resistant one. It's very strong. How will ions, calcium, the phosphate ones, leave the dentin and enamel if there's a boundary? Get my point? Have to say more? Then we end up with a potentially adhesive material that has been taken, that has the possibility for it to be an adhesive material taken away. If you put a boundary there. If we use a drill, we have a smear layer. If you use hand instruments, we leave a smear layer behind. And in order for the Glasionomer to work well, you have to remove that smear layer. If you move another layer in there, and put that Glasionomer on top, we take away one of the very nice characteristics of the Glasionomer. It's bonding. And then we come back to retention, niches, whatever, and then it may stick. And if the cavity has the pear shape, it will not fall out. But if you put a sloppy Glasionomer on top, it suddenly wears and dissolves. But we want good wines. We don't want the bad bogus wine where you get a headache next morning. We don't want that. So we go for the good material and don't mix with the Glasionomers in terms that I think I can do it better if there is no research backing it up. How many minutes have I?
Oh, you're still fine.
No, that's my comment to the gentleman. I like what you say, the man, very enthusiastic. But I still think that we do have to follow, let's say, more than NS1 studies. Am I make my,
yes.
You know, yes?
My only recommendation is, rather than respond to the previous, tell us what you are doing now and what you hope to do in the future.
How all of us, why haven't we had the last primary cavitated lesion perhaps done, I don't know, maybe 20, 30, 40, 50, depending how old you are, years ago? What was the main reason? In all of us. I had one was replaced after 50.
An explorer stick.
Explorer stick. But what causes that you most probably haven't been gone to the dentist to have a primary carious lesion to repair? Maybe a secondary care is possible, or break of a filling, yes, it's possible. But for primary, when was the last time?
Teenager.
Ages ago. What has helped you, us all, to get to that stage that we will see the dentist at the bar, perhaps, to have a drink? I like wine, I like beer also. Why is that? What is the reason for that?
12 crowns.
We have empowered ourselves thereafter. We know what we should and should not do. Do we? We know what we should and should not do. That empowerment should also go to the people in the outreach. And if you're there for one day, you cannot. If there's so many people with so many cavities, like you've experienced in SA, it's very difficult, but we have to empower those people, those young kids, the families. Then they carry it out, then they are their own master. Because there are too many. They're not 5 kids. They're not 5 adolescents. They're 5 million or 5 billion. No, wrong. Yeah. There are too many. And we cannot do it with all the best intentions that we have. We need to have more hands. And the hands are the hands of the people that have cavities. Those are the hands that we need to use. Those are the that extend our extension of care, of access to care. That's what's needed. And the silver diamond is very good in, and I would say that now, because the last time when we talked was it in Hong Kong 3-4 years ago, I was a bit skeptical when we sat at the table and talked about it. But it is when you leave the cavity open, because the tooth, the primary tooth, will exfoliate, and then you stop the caries progression. But at the same time, teach the child to keep that cavity free. And when you put the silver layer in it, you increase the chance for a reduction in sepsis and abscess and so forth. We've done studies where we didn't do it. We've studies where we opened cavities, make them cleansable, and taught the kids to clean. They did, after 3.5 years, there was no difference in healthy primary teeth survival, exfoliation, in comparison to a full amalgam and a full ART. Empower them, because we cannot, the cavities occur so fast, we cannot go, not even in one or not even in too many. We ourselves, I think, I don't know you all, but we have not developed carious lesions because we know what to do. Keep the plague away. I've not spoken about art. It's not. That's later.
Okay, I'm just going to tell them who you are. That's Joe Franken with Dr. Pilot in the Netherlands. Developed the ART, atraumatic restorative treatment protocol, which he did in Zimbabwe, they did in Malaysia, it's been done in Brazil and other places. So that's why he's on the program, because when I was in Saudi Arabia in 1984, he was in Zimbabwe, and I contacted him somehow and said, you know, this is what I'm doing, what are you doing? So this is before the internet, before email, and he was very kind to critique what I was doing, and this is the first time we've met, even though we corresponded and know each other for all these years. So now it's Dr. Richard Niederman. I'm not introducing you, you're from...
So
Right here.
What?
10 minutes.
my name is Rick Niederman. I'm from New York University College of Dentistry. So I'm a little hard of hearing, and I couldn't hear you in the back. Can you hear me with this?
I can hear you.
Okay, great. So if we could go up. And can you guys see this?
Yes.
Here's the clicker for you.
This one. cured them.
If you can figure that out, it'll be a miracle.
Okay, I'm just gonna keep going.
We may have to just deal with it.
And,
Oh.
there we go. All right. So this is the problem as I see it. This data from the Healthy People.
You need to stand on this side for the
Uh,
recording. I'm sorry.
All right, sorry. I'm used to walking around. The y-axis is a percentage of kids with untreated decay in the United States, and the x-axis are 5-year increments from 1985 to 2015. So essentially, over that 20-year period from 1990 to 2010, more or less, there, on average, there's 30% of U.S. kids have untreated decay. And for Native Americans, American Indians, it's almost 60%. Medicaid, minorities, rural are in between. And that has not changed over that 20-year period. Our goal in 1990 was to move down to 20%. In 2000, it was to move to 21%, and in 2010, it was to move the goal from 30% down to 26%. So over that same 20-year period, we spent in 1990 $1 billion a year to treat Medicaid kids, and in 2010, we spent $7 billion. We also, over that 20-year period, trained 30% more dentists and 60% more hygienists. So what we got for all that was a change in our goals. That's what the U.S. got for that 20-year period. So that's what I see our problem is. We're doing the same thing we've been doing, and we're training our students to do the same thing. So this is what I think could be if we did things differently. Sorry. What do I think the conflicting paradigms are? And it's that we treat comprehensive care in schools. That's what we teach at NYU, and that's what I learned, and it's based on a 19th century model. We could be doing comprehensive prevention. I don't think that NYU, Paige, you can correct me if I'm wrong, I don't think we have any guidelines or requirements to do comprehensive prevention, and we certainly don't speak to a 21st century model of care. So I'm going to share with you very briefly what we did in Massachusetts. Before I came to New York, I'm going to show you our first 6 schools. We grew the program to 55 schools, and we have programs now in Maine, New Hampshire, Kansas, Colorado, and Hawaii. So essentially, we generated a school-based program. So this started in 2003. We went into schools with a van and portable equipment. The only thing we needed electricity for was glass ionomer. We gave kids toothpaste and toothbrushes. We gave moral hygiene instruction. We did fluoride varnish, and we did glass ionomer classic sealants. And, you know, please forgive me, I'm calling these therapeutic sealants. And I started out by calling them temporary restorations because that's what hygienists were allowed to do in Massachusetts. So I did exams, hygienists were licensed. Actually, in Massachusetts, dental assistants can do temporary restorations. We had hygienists doing it. And we developed an electronic dental record, which we programmed information into. So I did the diagnosis, the treatment plan came up automatically, and then the hygienist would do the treatment. This is a detail. Each of these circles is one school. Again, this is the y-axis is the same that I showed you before. These numerical increments are 6 months, so we went in the fall and the spring. Each of these circles is a school of about 200, and we drove, when we started, this is the Native Americans, American Indian average, national goal for 2020. In the schools we were in, we started out 67% of the kids had untreated decay, and we drove that down to 21% in 6 years. I picked that as a primary outcome because it's something that parents, teachers, and politicians and insurers can understand, and we have a bunch more data that I'm not showing you. This acute abscesses on the y-axis, percentage of kids with acute pain, swelling, or infection by grade. The mean at the beginning, 17% of kids had acute pain, swelling, infection. The next visit was 4.5%, and then it went down to 0.5. It took us, on average, 20 minutes per kid. It cost $68 per kid per visit to do the care. We exceeded the Healthy People 2020 goals prior to 2010. We met all of the Institute of Medicine's 6 quality aims and the 3 Accountable Healthcare Act aims. So let me switch gears. This is a slide from Dr. Chu, who's sitting here. Rampant caries of a teen with beta thalassemia major and graft versus host disease, treated with silver diamine fluoride. Here are the radiographs, rampant caries. I clearly couldn't treat this in school like I did, but certainly with silver diamine fluoride, one could. So that's a high view. I have other war stories that I can share with you, which I think probably could come later. I do want to share a couple bits. We did a lot of analysis. We probably spent the last 2 years doing a deep dive into the data. And this is the probability of decay, and we dichotomized kids that didn't have decay at the beginning and kids that did. That's why they start at 1 and 0. In high-risk kids, in high-risk populations, high-risk families, high-risk schools, even if kids come in with no decay, they get decay and we can stabilize it. And these kids got same comprehensive prevention with sealants and everything else, fluoride. Each visit we saw them doing what we did, we reduced the probability of subsequent decay by 20%. And we sealed everything. So we looked at whether, this is whole teeth, y-axis percentage of kids with untreated decay. These are the whole teeth. The dashed line is just the occlusal surface, and this is the first molar. And I bring this up because a number of the programs we work with just wanted to seal first molars. And they were only seeing about half of the decay that was available to prevent from progressing. So ineffective just to seal first molars.
Is Dr. Dirks here? Come on down. Dr. Well, you'll tell your story.
I don't have any PowerPoints, but I'm glad to be following this last session because my job is funded by the Indian Health Service. And on one of the graphs there, you can see over the 20-year period that the disease has been not changed at all. And if you really look closely, it may be a little worse. As I say, I cannot speak for the IHS. I am tribally hired by the Porch Creek Indians. So I have to be really careful what I say here because the Indian Health Service is advisories to us. We do not have to follow what they dictate to us, but we really have to follow what they dictate to us, you know, the realities of the life. Okay? I came from, I'm a general dentist, and 90% of my time is doing general dentistry, and it has been. I, though, was trained under Paul Keyes. And I was trained in my private practice, I was with Jack Kane of Cincinnati, who independently, along with Paul Keyes, discovered the effect of fluoride on enamel back in '52. And then we pretty much were a periodontal practice. And when I retired and then came to southern Alabama, where the creeks are, I was shocked that caries was a problem. Because it really wasn't a problem in our practice. Perio and ortho was our main problems, our main thrust of our practice. So it was a little bit of a surprise, very much so. So this is back in 2003. I knew we had to do something, and so I kind of took the Keyes technique that I was fully using and kind of adapted it to a caries model. So initially in 2003, I started using glass cyanomer in these lesions, quickly changing to a resin modified because the glass cyanomer in our population, the compressive strength and all those other things just was not good. And in primary teeth. And in 2004, I added fluoride varnish to every patient, every visit, because we were going to follow this, because I was required to follow it by the IHS, because I was told to cease and desist on using fluoride varnish in 2004. Because it's, I was using it off-label. The person in charge of the IHS at the time was Dr. Blayhut, who just now retired, told the area dental office, he was standing right there when I was told to cease and desist. He said, no, 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 let him go on. I think he's onto something. And he says, then he told me, you have to follow every patient that you put on this fluoride varnish, which is not a hard thing to do in the Indian Health Service because our records are cradle to grave. And, you know, so it's actually pretty interesting. So we started doing that, and in 2010, I added pre-treatment of using fluoride varnish with 50% providone iodine. A minute treatment of providone iodine, then followed over with the fluoride varnish. Another tribe up in Alaska then adopted this, same technique. The tribe's out of Bethel, Alaska. And I, without me knowing about it, I happened to mention to the head dentist there at a dinner, and she took it back with her. And so I was really surprised a couple years later to find this out. And in 2012, we added.
How often would you provide iodine? Was it the basic maximum risk, or would you do it routinely every 3 months, every 6?
It's a risk-based, all right? Fluoride varnish, you really need to get 3 to 4 times a year. That's the downside of this technique. This is what we're hoping silver diamine fluoride will make this not possible because of in the Indian population, try to get them in.
Please scoot back
sorry.
if you can for the camera.
Can you hold the questions
Yes.
until the discussion group?
Okay.
Yeah.
But anyways, it's a risk-based, but we use it a lot. Okay? And then from the beginning, in 2003, we stressed reduction in oral destructive habits. Reduction in oral destructive habits, it's critical. It's a critical part of all this. All right? I follow the 10-year-olds. Our 10-year-olds are pretty much 75% caries and restoration free, which is pretty much like, as was pointed out, the white population is caries rates. And the occasional ECC that I see is a surprise. Those ECC patients are beyond dentistry. They have social problems that we cannot fix with fluoride, and we just have to deal with it. Those go to the hospital. We do 3 or 4 a year. Our tribe is small. The other tribes that have started using the silver nitrate, who have a lot of kids, I called up and they said, "Well, yeah, things are getting better. How much better? I don't really know." It was just always the problem. I said, maybe if you call the person that refers out to the pedodontist, you can get a better answer. It's just a feeling, that things are getting better. Now that we have elders with teeth, root caries is now in our population is the new ECC problem. Distal root caries, particularly root caries in general, but distal root caries is the #1 reason for extraction and endo procedures in our population. It's of course with age. It's of course with medications they're taking, and those medications can generally include crack, methamphetamines, and now heroin. So that's what we're finding. Oh, by the way, if you look through my charts, am I in the right spot?
You are now, yes.
Okay. ECC is it should be considered a high risk for future meth mouth. It's shocking if you go through my charts. Okay, so as to say, the #1, also too, what we're finding, which is what I'm really interested in, silver diamine fluoride, in an elderly population, if you suddenly start seeing mesial distal root caries on all teeth, maybe in 6 in a row, particularly in the lower anteriors, and in order to see them, you have to lift the gingiva up, and there they are. I can tell you this is, in my opinion, a high risk for an imminent CVA, particularly in certain populations. It's shocking. I have shocked the medical department. Like, you got to get over there, and of course it's too late, because it's not that the caries caused the problem. It's just, it's a parallel disease. It's not that, So we're hoping that silver diamine fluoride, in the IHS in general, will be able to negate the need of having 3 or 4 visits a year, because there's parts of Alaska, there's parts of the Navajo Nation, that if we can get the dentist in there once a year, we're doing good. Dr. Blayhud, who just retired, when he told me to pursue this, even though I'm not IHS and I'm tribally hired, he says, over the last 20 years, we've added all this dentists, we've opened up all these clinics, we've taken out all these teeth, we've done all these fillings, and we are the same as we were when we started. In fact, we're probably worse. So this is so, and he said to me, this is, he says, we have to do something.
Well, thank you. I'm really honored to have the chance to talk with you today. First, the caveat, I am not a dentist, and I'm honored to be here as a representative of the medical, public health, maternal child health profession. And I have to say, frankly, often I feel like a fish out of water. When I talk to dental people, I think there's the attitude, well, you're not inside our profession. What do you have to tell us? You haven't gone through all the training we have, and that's true. And I'm always learning from you, and I've been on such a steep learning curve, trying to learn about all the details of the tooth and the microbiology and all the treatments that you do. But my perspective from the medical and public health side is also really hard, because when I talk to my colleagues in medicine and public health, they say, why are you interested in the teeth? How important can that be? So I feel like I'm trying to bridge the professions and always learning and always trying to find new ways to talk to dental professionals like you about how to talk to the medical and public health side, so we can be speaking the same language, so we can be putting all of our efforts together to try to make a healthier future for the children. So in my day job, I'm a professor at UC Berkeley, UCSF Joint Medical Program, and I teach general medicine. I also teach in the School of Public Health there. And then on the volunteer side, my nights and weekends and all my vacation time, I devote to children's oral health globally. So actually I want to start back 35 years ago, after I graduated from college, I worked in the Peace Corps in Ecuador for 2 years in a rural area, and this is me back in the day. And I worked on child health and development, community health, and where I was working, it was a very poor village, and they had all of the health problems associated with poverty. Children had diarrheal disease, skin infections, respiratory disease, but I want you to take a look at the children's smiles. So tooth decay was not a problem back then, and I'm echoing what Rella said. Back then, people just ate straight from the farm. Fresh fruits, vegetables, milk, eggs, meat, and the children almost never had soda, sweetened beverages, junk food at all. And tooth decay wasn't a problem. This is the image that I keep in my mind every day of what children's smiles should look like. So then actually I came back to medical school, did my training, and 20 years later I returned to Latin America to start doing volunteer work. And this is what I saw. The old markets on the left sold fresh fruits and vegetables, and this is what the new markets look like now, selling a huge variety of processed junk foods and soda in huge volumes. Actually, here I took a photo of soda being sold 7 liters of soda at a time. 2 3.5 liter bottles hooked together by a sturdy plastic carrier. 7 liters for $1.29, and that's less than the cost of bottled water. So this is what's driving the problem. So this is what I saw. Returning to Ecuador, this is now 30 years later. This was a 5.5-year-old child. He had all of his 20 teeth decayed. Actually, we saw him the next year when he was 6.5. He had his 6-year molars. They were decayed as well. This was a rampant infection. And he is 5.5, and he weighed 27 pounds, which is the size of a 2-year-old. He was severely malnourished. He had constant mouth pain. He couldn't eat. He couldn't concentrate in school. This is the worst case scenario. And you might think, and I've actually read in the dental literature, this is a disease of poverty. But actually, his family was the most well-off family in the town. They owned the town store, which was actually set up right next to the school. And so the children on the way to school, at recess from school, on the way home from school, they stopped by the store. So they were doing very well, selling junk food and sweetened beverages. And he had 24-hour-a-day, 7-day-a-week access to junk food. This was driving his problem. So I started asking the people about this. I had never learned in my medical training anything about tooth decay. I was taught to examine the throat, open wide, and we look past the teeth, and we just look at the back of the throat. So this was all new to me when I started seeing this. The mothers all told me, my children's teeth are rotten, they complain of pain all the time. They can't eat, they can't sleep, they can't play, they can't concentrate in school. So I realized this is not just the teeth. This affects the whole nutrition, health, educational potential for children. And I started asking the dentist, and they said, well, we're bringing toothbrushing into the schools starting at age 6. And I realized that is way too late. So over the past 11 years, actually, I've had a chance to work in all of these countries. I brought groups of volunteers, including Ben Chaffee came to El Salvador with us. And we've had almost 300 volunteers working with us on this, mostly undergraduate students, but also medical students, dental students, public health students, and health professionals. And unfortunately, we find the same thing everywhere. Junk food is everywhere, and this disease is progressing everywhere. So I just want to point out a little data from our studies. At what age does this start and how does it progress? Here you can see parents giving their infants junk food. So this is just some preliminary data from a couple countries where we have convenience samples of populations of children in the communities, from El Salvador, from India here. And what you see the same as both, this is the prevalence of tooth decay by age from birth to age 6. And what you see is starting in the first year of life, just this steady increase in the prevalence of tooth decay, so that by 6 years of age, over 90% of the children have tooth decay. This is the average number of decay, missing, and filled teeth. Actually, in this case, virtually all were untreated in these children. Again, the inexorable rise in the number of caries in these decayed teeth in these children, up to 7 or 8 at age 6. So from the pediatrician standpoint, I see that as a third to half of the children's teeth are decayed. That's a huge burden. And I just want to show you a little data from Ecuador. This brilliant young dentist from New Zealand, Bethy Turton, who's been working in Cambodia for many years. She came and worked with us in Ecuador, and she did a little graphic representation. And what she did is she took our baseline data, and she's representing a graphic representation of the teeth. You'll see the teeth sort of splayed out in visual, and as the percentage of children in the population are increasing prevalence of caries, you'll see the teeth turning pink to darker red to dark red. So you'll actually be able to see the prevalence of caries in each teeth in the population by age over time. So I'll show you this. Okay, this is 1-year-olds in our Ecuador population. We had about 700 children. So you see, even in 1-year-olds, there are some teeth here that are starting to decay. 2-year-olds, 3-year-olds, 4-year-olds, 5-year-olds, 6-year-olds. Okay? Shocking. So what can be done? Clearly, there's a huge burden of treatment. These children are suffering, they need treatment, but I believe that we're not going to get anywhere unless we focus on prevention, including preventing the causes, what the drivers of this, which is the nutrition transition. So here's a little graphic that I made to show this, thinking about the balance between prevention and treatment. Here are a population of children in which, say, 80% have caries. And basically, when we have a disease that's so prevalent in the population, we're never going to have enough dentists to treat them. And especially in developing countries, there are so few dentists, there's no hope of ever having enough to treat. And then the dentist who might see a few of the children, occasionally you'll get a perfect result, but sometimes they can only extract the one worst tooth there. But if we get, say, community health workers or dental nurses out into the community, focusing on prevention and maybe even treatment with silver nitrate or other things, and we can reduce the burden of disease in the population, and also at the same time refer the children with the most severe disease to dental treatment, then we're actually going to have a better result on this side and a population in which we don't have such a burden of disease, and a happier tomorrow. So that's what I'm thinking. Again, the balance between prevention and treatment is very important. This is the intervention that we're doing. It's not perfect. We're trying to build on things other people have done. Prevention beginning in infancy, education on nutrition and oral health for community health workers, and they in turn educate the parents and children. Free toothbrushes and toothpaste, for fluoride toothpaste for all family members, not just for the children, because the parents also have this disease. We apply fluoride varnish on children's teeth 2 to 3 times per year, and then we refer the children to dental care. So I'm particularly interested in the connection between tooth decay and malnutrition in children. So this is what we know the causes of tooth decay. It's destroying the teeth, causing mouth pain, and chronic inflammation could contribute to malnutrition. And I'm hoping that by prevention, with good oral hygiene, good diet, we can reduce tooth decay and reduce those dental problems and reduce malnutrition. So I want to share a few just preliminary results with you from Ecuador, back to Ecuador. Here's our team. We're working in an indigenous community in the Amazon jungle region of Ecuador. They seem to be particularly susceptible to caries, like our Native American population in the United States and in Canada as well. Here's some of our designs. This is community-based. We only have pre and post intervention, no control. I didn't think that that was ethical, and we didn't have the resources to do it. It's like an Indian reservation where we're working. We have children 6 months through 6 years of age. We're trying to cover all of the children and families in the region. And we're collecting data yearly by interviews with the mothers and exams of the children, both dental and height and weight for nutrition. So many study limitations. So this is just preliminary. I just want to show you the caries experience by age. So actually in Ecuador, the prevalence of caries goes up so much faster than the other countries that we saw, so that by 1 year of age, already 50% of the kids had caries. By 2 years of age, over 80% had caries. And by 3 years of age, they're over 90% do. And you can see here the rise in DMFT as well, very fast, so that by 6 years of age, DMFT of 10 to 11. But this is the blue is our 2011 cross section, and the red is the 2013. And I want to show, but by our intervention, again, it's limited. We're not using a powerful antibacterial like silver nitrate. We've at least gotten the kids on a different trajectory, slightly slower increase in the prevalence of caries and slightly slower gain in DMFT for the children. But this is still tragic, still tragic. What I've realized is we need a much stronger antibacterial. These kids are still suffering, and the disease is rampant even with our intensive intervention. Here's the prevalence of mouth pain too. We've been able to control it somewhat with our intervention, but still we have a long way to go. And malnutrition too. This is the longitudinal sample, so a smaller proportion of children we were actually able to see 3 years in a row. And so these children here, 2 years later, they're here. These children here, 2 years later, they're here. And this is their malnutrition, height for age malnutrition or stunting, which has been a chronic problem throughout the developing world, and it's hard to reduce. But here we see that these children who started from birth have actually benefited from our intervention and have a substantial reduction in their malnutrition compared to where they were expected to be, compared to their older siblings, say, who are 2 years older, and these children too have a reduced malnutrition compared to their older siblings. So just in summary, I want to say we need to understand this caries pandemic in the context of the other malnutrition and obesity pandemics, all connected by the processed foods and drinks. So we shouldn't be just saying we want to help the teeth, and then we'll still have children who are consuming the junk food and the sugar-sweetened beverages, and they'll have beautiful teeth, but they're going to be obese with diabetes, kidney failure, heart disease, and all of that. We need to address the whole picture there. And so here's my message to the dental community. One, collaborate with medical and public health professionals and systems. Thinking not only of intervening through dental clinics and dentists. Of course, there are not going to be enough dentists throughout the world, but also through maternal child health systems, community health workers, nurses, preschool teachers, and publish in the medical and public health journals. When you publish in the dental journals, you're preaching to the choir. The medical and public health community needs to see this. I was just shocked. I don't know whether you all are familiar with the malnutrition literature, but the Lancet every 5 years comes out with everything that's known about child malnutrition. It's a series of articles on child malnutrition, and the recent one was put out in 2013. And they listed all the causes of child malnutrition in the developing world, thousands of references. There was not one mention of tooth decay or mouth pain contributing to malnutrition. And Habib Benzian and I wrote a letter to the editor afterwards that wasn't published, and they said that the literature is not there to show the connection between tooth decay and malnutrition, which is shocking. You all have been publishing about this. So anyway, publish in medical journals, address the oral health and the nutrition contributors of caries, focus on treatment and prevention, start from birth. Most of us go to schools to intervene. At 6 years of age, it's too late. Start from birth and prenatal, ideally. Measure the successes. Don't just look at the teeth. We've reduced DMFT. Also look at quality of life, mouth pain, nutrition status, and school attendance, and performance and cost effectiveness. So I just want to leave you with a thought from one of the Salvadoran families who participated in intervention. They said, the mother said, we used to think there was nothing we could do about our children's rotten teeth and mouth pain. It was just a fact of life here. But now, childhood doesn't have to be a time of pain and malnutrition. It can be a time of good health and happiness. This is what I believe all children in the world deserve, and I hope we can work on making that a reality. Thank you.